Okay, we will get started now. We are supposed to have 4 speakers. I have not seen the 4th person, but for now, we have 3 speakers ready. And I will start by first calling Frida Yaga. Frida is a monitoring and evaluation research manager. She comes with over 13 years of experience in monitoring, evaluation, and research, has supported a number of projects in Kenya on obstetric fistula, life after birth, and also in the learning field. She was part of a team that implemented post-pregnancy family planning in Kenya, and also part of RMNCH program. And her presentation on understanding pregnancy for immediate immediate postpartum care among adolescents. Frida, you may want to comment. Just to say that you have a total of 15 minutes. I will do a hard stop. I will remind you, like 5 minutes, all the presenters before time, and please try to stick to time. Thank you.
Hi, everyone. My name is Frida Nyaga. I'll be taking you through the key findings from the longitudinal post-pregnancy family planning study in Kenya. And this is just to understand the pregnant adolescents for better immediate postpartum family planning programming. Most of you in this room knows that 21 million girls in the developing countries become pregnant every year, age 15 to 19. And half of these pregnancies are unintended, and half of them end up in abortion, and sometimes in those unsafe conditions. And we've also known that 18% of the adolescent pregnancies are either second or even higher under pregnancy. And this brings us to a problem. This is teenage pregnancy is a global issue. This is because it leads to negative health outcomes and also leads to increased maternal and neonatal mortality and morbidity. And introduction of the modern contraceptive use is gonna help childbirth to increase the contraceptive use, and this is likely to reduce the unintended pregnancies or pregnancies that are too close spaced. And we know that when we do better programming of the adolescent, we are likely to have positive health outcomes and also lead to the sustainable development goals related to maternal and neonat-born health. This project was carried out in Kenya, and Kenya has 47 counties, and this took place in 2 counties, which was an intervention county, Meru County in the middle, and Kilifi County. The aim of this study was to look at advancement of learning about the provision, the uptake, and continuation of full range of contraceptives that are offered immediately after birth. And this was in both public and private facilities. It's a quasi-experimental study that involved intervention and control harms. And each of these county and 11 study sites and 12 implementation sites, with support from Bill and Melinda Gates and MSD for mothers. Overall, the goal was to generate actionable evidence and use in improving the post-pregnancy family planning programming with research questions around what is the greatest influence on immediate post-pregnancy family planning decision-making among the adolescent, and if these immediate family planning methods intervention are associated with increased uptake of the methods among the adolescent. The study started in 2017, and along the way, we had some study timelines. The first intervention was to look at the introducing this study to the counties, and also coming up with the package of intervention, and also carrying out some baseline assessment. And then in the year 2018, both in the intervention counties and the control counties, there was data collection. And in the intervention counties, we rolled out the package of intervention. In 2019, again, in the intervention county, we continued with the intervention and data collection, and in the control county, we introduced the intervention as well as collecting the data. And still in 2020, the data collection and of the study data continued in the two counties. A number of interventions were done, first in the intervention counties, and around creating awareness of this intervention, training the healthcare providers on the provision of immediate post-pregnancy family planning services. Also carrying out mentorship program just to ensure that these facilities are able to identify their gaps and address them. A number of activities around creation of audio messages and video messages, just to ensure that when the healthcare providers are overwhelmed in terms of talking to the one-on-one counseling, they can, the client can sit in and listen to the audio messages and understand what it takes for them to take up a method immediately after delivery, including the animated video that would play when they are waiting for the services. Beyond that, the project provided equipment at the service delivery point. This is because traditionally family planning is provided when they not in the service delivery point, but introducing this service in the service delivery point means reorganization of services. Commodity management was key, ensuring that we are able to monitor the flow of the commodities and ensure that whenever there is a stock out of commodities, then the facilities are able to redistribute the commodities to ensure no mother misses the commodities when they need them. And ensuring that focusing quantification of those commodities is done well to improve accuracy and timely reporting. Then advocacy of the IPPFP services, including some of the high IPPFP indicators in the national health management systems. This being a longitudinal quantitative data collection method, the data collection was done in 4 points, all the way from 2018 to 2020. And the recruitment of these mothers was done at ANC for all women who end 28 gestation. And all the mothers that were recruited in the study were followed through during delivery, and they were interviewed within 48 hours of delivery in all the facilities, and they were interviewed again at 6 months, and later again at 12 months. A sample of 4,508 and a number of 4,494 were recruited. Out of these, 504 were adolescents, and the rest were adults. So most of these adolescents were married. This is 73%. And you can see that 84% of them were aged 17 to 19 years. And out of the most of them had primary or even less education, 73%, and 58% were married. And then around 16% reported previous pregnancies. And when you compare out of the numbers that were interviewed during immediately after delivery, you notice that 58% of the adolescents had reporting that the pregnancy was not intended. And again, you can see that more adolescents, a number of adolescents, 5%, saying they were not doing anything to prevent pregnancy. When you ask them about the intention to use immediate post-pregnancy family planning method, again, in the intervention counties where the interventions were provided, 85% said yes, they had intention to use the family planning method. Looking at the adolescent who could choose a method if others disagreed. And this is very key because here they would mention that if a friend disagreed, they will still take a method. If a religious leader disagreed, they will still take a method, or a partner. Or again, if a provider disagreed, there are less of them will likely take a method. So the provider component is very key to ensure that adolescents are able to take up a method. And this is the uptake of the methods. Immediately after delivery, we found out that in the intervention counties, 27% of the adolescents took up a method. And you can see it's not very far from the adults, almost 30% of the adults who took a method at the same time. So it means that when we do these interventions within the intervention county, more adolescents take up the method. More to that, 97% of the adolescents who took up the method made the decisions themselves. So this is very key again. And then 99% of the adolescents are saying that they would recommend this method to a friend. And this is immediately after delivery. So what are we saying? That I'm gonna finalize that if we do this intervention, we are able to improve a lot on uptake of the IPPFP among the adolescents, and that most of the pregnancies that we've seen from adolescents are intended, and we have also seen that prioritizing on the provider is very key to ensure that they are able to provide these services. And finally, I'll just remind everyone that there is a growing global, regional, national commitment to provide child marriages and adolescent pregnancy and childbearing. Thank you.
Thank you very much, Frida. I'd like to call the next speaker, Francis Xavier A. John. Francis is a senior program officer with Population Council in India. And his presentation is on correlates of contraceptive self-efficacy among adolescents in Rajasthan. Over to you, Frank.
Thank you for the introduction. Good afternoon to all. I will discuss about the correlates of contraceptive self-efficacy among adolescents in Rajasthan. So contraceptive self-efficacy measures the strength of adolescents' conviction that they could use or demand contraception in sexual relationships. Evidence indicates that knowledge about contraception and availability of contraception is not alone sufficient for adolescents to go for use contraception. So rather motivation and willingness are necessary to translate knowledge into action. So in India, many adolescents are going for risky sexual relationships, leading to unintended pregnancy, sexually transmitted infections and all. So in India and in global literature, this contraceptive self-efficacy is very little studied. And the studies that is available many studies are not quantified the contraceptive self-efficacy. So we aims to study the levels and correlates of contraceptive self-efficacy among adolescents in Rajasthan. So the data we have drawn from a community-based survey which is part of the FIA evaluation. It's a project. FIA means youth-led advocacy for sexual education. The baseline survey was conducted in 2019, and we covered 88 villages from 3 districts of Rajasthan, which is in India. And we interviewed around 3,200 adolescents, boys and girls of age 13 to 19 years. But the focus of this paper is around 1,200 unmarried boys and girls aged 15 to 19 years. So we have used factor analysis, descriptive analysis, and latent class analysis and bivariate logistic regression. So to measure the contraceptive self-efficacy, we have used 11 statements. Statements like, for example, how upset will you feel if you get pregnant? And how confident are you that you will be able to discuss with your partner about using contraception? How important will it be for you to use contraceptive methods? Like these 11 statements we have used. And we applied a latent class analysis. And based on the latent class analysis results, we could able to group the boys and girls separately into high and low self-efficacy group. So these are the explanatory variables that we have used in the regression model, that household characteristics and individual characteristics, that is age, education, and paid work, and indicators of agency. We used factor analysis to reduce this indicators agency into 3 groups, like decision-making agency, and agency for mobility, and general self-efficacy. And these factor scores were then normalized to range between 0 and 100. And then index of gender role attitudes we have used, which is based on 23 statements, which is an additive measure. And 3 indicators of sexual and reproductive health knowledge, again we selected, which is one is in-depth knowledge of any 5 modern contraceptive methods. And second is accessed health services or received services from any healthcare providers. These are adolescent health services. And have pro-condom attitudes, which is measured using 4 statements, like a condom reduces sexual pleasure, or a condom can slip off man and disappear into woman's body, and a condom can prevent STI, or 2 condoms offer more protection than a single condom. And if the adolescents say correct answer in all these 4 statements, we consider them as having pro-condom attitude. And the last one is ever engaged in premarital sexual relationships. So these are the profile of study participants. I just say 2 variables only. One is around 17 to 19% of the adolescents are ever engaged in premarital sexual experience in our sample. And this is the comparison of contraceptive self-efficacy by background characteristics. And as I mentioned earlier, we did latent class analysis to group the boys and girls separately into high and low contraceptive self-efficacy. And if you see more girls, 66% of the girls as compared to 61% of the boys reported that they are contraceptive self-efficacy is high. And if you see by other background characteristics, those who are currently in school for both boys and girls and have pro-condom attitudes and in-depth knowledge of modern family planning methods are, they are more likely to have a reported high contraceptive self-efficacy. So finally, we did logistic regression, and in the logistic regression also supported the bivariate analysis. And if you see the women who, boys and girls who were currently in school, were more likely to have reported high contraceptive self-efficacy, their odds are around 2. And similarly, those who have a high index of general self-efficacy and index of general gender role attitudes are high, they are also more likely to report high gender role attitudes. Sorry, high contraceptive self-efficacy. And in addition, for boys, age and never engaged in paid work and pro-condom attitude and index of awareness of modern contraceptive methods and engaged in premarital sexual relations also became an important variable. So to conclude, the perceived contraceptive self-efficacy among adolescent boys and girls is limited in Rajasthan. And we found a number of variables important which is correlated with contraceptive self-efficacy. So to improve contraceptive self-efficacy among adolescents, apart from education, interventions to build their agency and sexual education programs are needed. Although the government recognizes the need for sexual education, but little effort has been made to create an enabling environment for adolescents so that they can make informed choices. Thank you.
Thank you so much. I'll call the third and final speaker for this session, Vladimira Kantanova. Forgive me if I... And her presentation is Preparing for Family Planning Needs of Adolescents and Youth.
Good afternoon. So my name is Vladimira Kantorova. I work in the United Nations Population Division. And two of my colleagues, wonderful colleagues, who are also co-authors on this presentation, Julia and Mark, are here in the room. So our presentation is about preparing for the family planning needs of adolescents and youth. So after two presentations, which were on the countries, we will really bring it to the global level and make the comparative perspective and look at the population estimates, but also on the projections. Using the data from the population division, so World Population Prospects 2022 revision, and family planning datasets and other datasets. So it's as you all, so why should we be interested in demographic trends of adolescent and youth? One of them is the view from the individual level. Child marriage and unintended pregnancy have long-term implications for adolescents and youth. Events in adolescent years carry forward into later ages, making this a critical time for interventions. But it is also important from the population level because informed planning for future population of adolescents and youth can accelerate progress on many different indicators related to education, health, gender equality. And this information is also relevant for those investing in adolescents, youth, and their human capital, and for reaping the benefits of changing age structures. So this analysis sets a global perspective for a discussion on demographic dividend and investments in the sexual and reproductive health and rights for adolescents and youth. So as you all know, yesterday was the day of the 8 billion, and plus minus couple of months, but it's the 8 billion, 15th November. And of these 8 billion, the population of 10 to 24-year-olds, it's 1.9 billion, which is around 24% of the population. Currently, we still experience the largest ever population of adolescents and youth, and the growth of global population of 10 to 24 years old is continuing and will reach maximum size around year 2030. And then you see kind of like more of these stable levels with up and downs. And then after year 2070, the population starts to decline. So the largest populations of adolescents, when we look at these big regions of the world, are in Asia. So for a long period of the time, it was the Eastern Asia, Eastern and Southeastern Asia, so which is the region containing also China. And around 2000, it was because of the population growth of India being faster than in China. So from 2000, it's the Southern Asia and Central Asia region together, which is now having the home to the largest population of adolescents. And you also see this very fast increase in Sub-Saharan Africa. That's that violet line. So what's happening in the future? After 2040, Sub-Saharan Africa will have more adolescents and youth than other regions. And according to median projection, the number of adolescents and youth in Sub-Saharan Africa will double between now and 2080. So it's within the period of 60 years. And from now on, both of the regions in Asia will see the decline in the numbers of adolescents and youth, and very rapid one actually in the Eastern Asia. So we can also look at the level of the countries. So instead of looking at the regions, we can look at the countries. And here we compare the ratio of population age 15-19 in 2040 compared to 2021. So it's the increase in the population in the next 20 years by income level. So, and the colors are again the regions. So the violet one is again Sub-Saharan Africa, the two blue one are the Asian regions, and the size of the marker is the proportional to the population size in 2021 of the age group 2024. So by 2040, population of adolescents and youth will increase by more than 50% in 22 countries. Most of them are in Sub-Saharan Africa. And the highest increase is in countries with low income. So there's an additional need to plan for large expansion of services for adolescents and youth. In most countries outside of Sub-Saharan Africa, there's small or no increase in the population of youth and adolescents expected. And again, you see these two biggest circles are the India and China. And both of these countries, we expect actually to decline in the population of youth and adolescents. And some of these top countries are Niger, which will experience the doubling of the population of youth and adolescents. And the other countries are Democratic Republic of the Congo and I think Angola are among these large ones, where it's more than, I think, 75%. So what we also know from the demographic trends that fewer adolescents are married or in union. So this is the figure with the proportion married or in union women by these large regions. And you see this very rapid decline in Southern Asia. That's really, again, India. And a much slower decline in Sub-Saharan Africa. And remaining at relatively high levels in Latin America and not declining in Oceania, just excluding the New Zealand and Australia. And you also see this big difference to other regions of the developed Europe and yeah. So around the World Population Prospects for the first time in this revision also published the estimates of the adolescent birth rates for girls aged 10 to 14. So it's for the first time that we have the global estimates. And it's actually kind of, I have to acknowledge David Paez Sanchez, who helped us with some of the data for which are underlying these estimates. So around 500,000 girls under age 15 every year give birth. The experience of becoming a mother for girls below age 15 is most common in Sub-Saharan Africa, with nearly 5 births per 1,000 girls aged 10 to 14. But it's also high in Latin America and Caribbean, which is surprising because overall relatively low fertility levels. And outside of Sub-Saharan Africa, it is still high, so higher than 2 per 1,000 in Afghanistan, Bangladesh, and Laos. So adolescent birth rates have declined since 2000. And again, you see the biggest decline in the Southern and Central Asia, which is again India. That's this kind of like seeing both the same patterns in the marriage and the adolescent birth rate. And here you kind of, it's for both age groups, but mind the kind of the different scale on the axis. In other regions with high adolescent birth rates, the decline is much slower. So globally, so what's important to understand for the adolescent childbearing is also the differences on the context. So globally, around 77% of girls, of births to girls under age 18 are in marriage and union. However, there are very large country differences. So in Southern Asia, Western Asia, Northern Africa, more than 90% are in marriage. While we see in many countries of Sub-Saharan Africa, especially the southern one, and the Latin America and Caribbean, it's actually less than 75%, and in some countries less than 50. And I'm getting to last two slides. It's on kind of what we see from the contraceptive use patterns by age. So when we look at contraceptive use, this is by age groups, we see that when we look at it's among all girls and women in these age groups. The lowest contraceptive use is in the age groups 15, 19, 20, 24, which is again related to marriage and union formation patterns and lower proportion of sexually active in these youngest ages. However, the unmet need for family planning is comparable to other age groups, and especially what you see, it's like for the age group 20 to 24. The 15, 19 is low. What it means in terms of when we look at the demand satisfied, these are especially the demand satisfied by modern methods, it's lowest for young women and girls compared to other age groups. And this is global estimates, and we can again look at the country situation. So here is it's the age group 20 to 24. And we see that half or less of women age 20 to 24 use modern methods in Southern Asia, Central and Western Asia, and Oceania, which is again compared to the 80 or more than 90% in Europe and parts of the Latin America and the Caribbean. Globally, the number of women with unmet need for family planning is around 15 million for women aged 15-19 and 30 million for women aged 20 to 24. And these levels are relatively stable. However, what's changed is where the girls are. So in the 1990s, it was really Southern Asia. And we see the Southern Asia decline because of the progress in meeting needs for family planning, but also the decline in the proportion married. So that's, over the same period of the time, we see the increase in the Sub-Saharan Africa due to large population growth in the numbers of girls in these age groups. And I have the last slide. So planning for future adolescents and youth benefit from demographic foresights. And we need to understand that changes in population size of adolescents and youth in coming decades are largely foreseeable. So we should be really basing our policies and intervention on this data, because we know pretty well what's going to happen. These are the children which are, part of them, already born. Countries that will experience largest increase in population of adolescent and youth in coming 20 years have also high burden of child marriage, high adolescent birth rates, and low use of modern contraception among women who want to avoid pregnancy. Many of these countries are low income and in Sub-Saharan Africa, and especially for these countries, additional resources are needed for scaling up of sexual and reproductive health services and interventions to reach the growing numbers of adolescents and youth. Progress in reducing the burden of early childbearing requires intervention specific to the context. So this we have seen from that very wide differences in the proportion of the married. Our findings are important to keep in mind for those investing in adolescents and youth and their human capital needed to reap the benefits of changed age structure and demographic dividend. Thank you for your attention. And on the last slide, I have just the list of the resources and all this publication you will find on the Population Division website. And thank you very much.
Thank you very much, Vladimira, and thank you to all the speakers. This session is really about adolescents. The first speaker focused on services, particularly postpartum service, immediate postpartum services for adolescents. And of course, the second speaker, Francis, spoke about the importance of comprehensive sexuality education and the fact that there is higher knowledge and use of contraceptives for those who do have CSE. And then Vladimira talked about the bigger demographic picture, really looking at demographic trends and really looking at the demographic transition and what needs to be done in terms of policy when looking at the transition. And the good thing is she showed, the various regions across the world. So if you have any questions for any of the speakers or for all of them, or any comments, now is the time for you to ask questions. Questions or comments? Okay. Thank you.
Thank you very much for the presentations. I have a question for the first speaker. What is the proportion of the deliveries in the hospitals as well as in the community, and which ones deliver the most in terms of immediate postpartum family planning? And for the second speaker, I'm just curious, when do you introduce CSE in schools? And I couldn't remember the educational level of attainment for the respondents of the survey. And then for the last speaker, are you saying that what we're doing right now in Asia in addressing adolescent pregnancies is the way to go, since there is a decreasing trend in the future? Thank you.
I have a question to Francis, and actually maybe both, because so when looking at the survey data, and these are very sensitive questions to ask to 15, 19-year-olds. And so I wonder, what's your experience? Can you talk to us? Is it the household-based surveys or more in the school? How you actually get the 15, 19-year-olds to answer these questions and about the process? And maybe it's similar to you because you have also the same age group to, if you can a little bit tell us about the process. Thank you.
Okay, first, shall I go first? Yeah. So, regarding that education level, these are women, adolescents aged 15 to 19 years. So still they were in school, like 74% of the females and 86% of the males were in school at that time. So that they continued after 12th, right? Yeah. So, see, these are sensitive questions. So the survey was, we conducted for 13 to 19-year-old, but these sensitive questions we asked only to 15 to 19-year-old. And this intervention is not school-based. This is actually a community-based one. We formed, the Population Foundation of India, this is a different organization. They implemented this project in the field. We are only the evaluators. What they did was that they formed several adolescent groups, and they are the first direct beneficiaries of the program. And then these adolescents are asked to contact another 10, 15 adolescents. They are the indirect beneficiaries. Like, that was the direct beneficiaries and indirect, that was the plan. And asking sensitive questions, we have good experience in asking these questions because we conducted several adolescent survey and asked about their sexual experiences and all. So what we did was that we first talked to these adolescents and then we privately, out of the house or in a private place, we interview them alone. So, I mean, there is no problem we experience right now. So at the end of the survey, like sexual experiences, people may not reveal in face-to-face interview. So what we usually do is that we give an envelope saying that have you ever experienced, did a sexual experience or used the contraception? Two questions with the two boxes. So they just have to click yes or no. So, so many people there, they say, I did this. Yeah.
Thank you.
I think you forgot to answer. At what level in the educational system do you introduce CSE?
Oh, I think that is in high school, 8 to 9. Yeah, that is a government program. But this is community-based. This intervention is community-based, but the government schools, as per the government education system, it's 9 standards onwards. This is there. Sex education program is there.
Just a quick follow-up question to that. Did you involve any out-of-school youth, or it's mostly just those in school?
Yeah, this is, as I said, it's a community-based, so both are there.
Okay, thank you.
Yeah.
Go ahead, Frida.
That's a good question about the proportion of women delivering in the facilities. In Kenya, according to the previous survey, we've seen that most women deliver in the health facility, around 61%. That doesn't mean that we do not have challenges with deliveries, especially mentioning that adolescents also face unsafe abortion. And of course, those happen outside the facilities. Just to mention that we have post-abortion care services. In case that happens, then the facilities are able to provide those post-abortion care services at the facility level. And then for the second question, for the adolescents that we interviewed in the survey, all of them were interviewed at the ANC clinic, the antenatal care clinic. When they came in for the antenatal care services, they were recruited, and again, they were interviewed when they came to deliver in those study facilities. And they were followed again at their homes at 6 months, and after at 12 months, just to see whether they, even those who did not take up a method immediately after delivery, if they were able to take a method at 6 months or at 12 months.
Thank you, Frida.
So for the adolescent pregnancies in Asia, there's a lot potentially to learn from the experience of Asian countries, but it's also important to understand, the figure which I was showing about the relationship with the marriage. Because it seems like it's from the evidence what we see, it's a both decline in the marriage, driving adolescent birth rate declines. And that situation is very different in the sub-Saharan Africa context. Not in some countries, it might be very similar. In the countries like, I think it was Ethiopia, Niger, and Chad, which have high proportion of births below age 18 happening within marriage. But there are other countries which still have very high adolescent birth rate where this is not true. So potentially the interventions need to actually to be different than what was happening in Southern Asia. And it's also, I mean, it's maybe interesting also question for the discussion with the Indian colleagues. It's how fast the decline is. And we see it both in the sample registration system data, and also it's a slightly different level at the DHS. So it's, yeah, I would maybe afterwards, I would like to hear your inputs on the quality of the data and what's happening. Thank you.
Yes, please, go ahead.
Hi, I just wanted to ask a follow-up question about the marriage and whether you knew when looking at that data if it's in union or marriage at the time of conception or at the time of birth.
So I have not shown it here, but we have also, so we have those which are happening both pregnancy, start of the pregnancy and birth are not in marriage. Then it's the period of 7 months that it's just after the marriage. So it's we assume that the pregnancy is before marriage and the marriage is around a similar time, or it's actually marriage might be sped up or maybe because of the pregnancy. So, and that's interesting because it's a relatively stable proportion. It's around 10 to 15% in many countries around the world. So even in countries in Southern Asia, where you see very high proportion of births below age 18 happening in marriage, there is still a proportion of the births which are these premarital one, where the pregnancy is premarital. So it's existing everywhere, and in the very, yeah. So we can see it in the data, and it's pretty, stable everywhere.
Thank you very much. Are there other questions? You know, the issue of adolescents, it's really very, very important, particularly around both the education, the access to services, whether adolescents are in union or not. It seems to me we still keep talking about the issue of adolescents, and we still keep having problems, and we still keep talking about religious, cultural issues that, are affecting access to services and information for adolescents. So the work that you're all doing, I think, really contributes very much to the knowledge that we're gathering in this meeting. And thank you very much for sharing the resources, Vladimira. I think that is very, very important. And, I had wanted to ask, about the postpartum family planning, but I realized we're not talking about methods. It's generally access to postpartum family planning, and that is really important. So I would like to thank you all for coming, and to the speakers. Thank you very much, and see you around at the end of the session.